Hello, thanks for listening to the Total Knee Tips and Pearls podcast. This is Adam Rosen, your host. I'm a fellowship-trained orthopedic surgeon who specializes in joint replacement. In these episodes, I'm going to share with you a lot of my tips and tricks and review classic articles and current implant designs. Thanks for tuning in, and on with the show. Hello and welcome back. This is Adam Rosen, and you're listening to the Total Knee Tips and Pearls podcast. In today's episode, I want to do my best to talk to you about stiffness and how you can potentially stop a problem before it becomes a significant long-term issue for a lot of these post-operative patients. So, range of motion is really important. You've heard me talk about it before, and it's extremely important to begin this discussion with patients in the preoperative setting as to how important it is for them to do physical therapy and to get early range of motion, as later on they can't gain the motion that they may want. And, I think we all know, and you can read all of the studies that show that manipulations are most effective in the first 12 weeks. Why? Well, because after 12 weeks, that scar tissue is more mature. But you can also extrapolate from that information that patients really can only get motion, whether or not from them or from us, in the first 12 weeks. So I really stress to my patients that they need to achieve the motion early, and they need to achieve the motion first. That will give them long-term benefits. If they're weak, at 12 weeks, you can still get stronger after 12 weeks, and they can do that on their own. But you need to let these patients know that it is so important to get the motion early on and understand that they get no second chances. And I discuss it exactly like that with my patients. I say, listen, when it comes to the motion, this is one of those things in life. You get one chance. There is no do-over. So if you're going to go into this, you need to go in with 110% effort to get the motion. So that is part of the discussion early on. Patients have to understand that going in. And again, I don't really believe that what I do surgically is any different from the next person. So I believe that everybody can put a good total knee in. A few simple things that I really think are important during the operation that can help a patient get range of motion. One obviously is restoring the joint line and good balancing. Obviously, if you mess those up, it's really difficult for some patients to get good range of motion. So that's sort of a no-brainer. You want to put in a good total knee, make sure you've restored the joint line and created good balancing in the knee. But two, the other little tip or pearl you've heard me talk about before, though, is that once the implant is in, especially cemented, or if you're using press fit on the femur, is take the bovie and go around the superior aspect of the femoral component, that anterior flange, and make sure that no synovium has gotten caught underneath that, because I believe that functions as a tether, and as patients bend, it's like someone's pulling their hair, and that pulling inside stops them from bending further due to the pain. So you want to make sure that none of that synovium has gotten caught under the implant when you actually implant the real total knee femoral component. And then the third thing that I do, which I do believe makes a big difference, is that postoperative photograph that you've heard me talk about, which is once the knee is completed, the incision's closed, the dressings are on. Just before we wake the patient up is lifting that leg up, letting gravity bend it, shooting a picture from the side, and giving that picture to the patient just to let them know that when they bend their knee in physical therapy and it hurts, that they're not hurting anything, they're not breaking anything, and that picture just allows them to know and see that their knee can go back all the way, and that gives them a goal of what they're shooting for. So when you see stiffness really depends on when you see your patients for follow-up. When I used to use staples years ago, they used to come in at the 12, 14-day mark, and they would see my nurse. And, my nurse was great, and she would come grab me out of another room and put me in the room if she caught someone that wasn't bending their knee. She knew right away, hey, sitting in a chair, you got your knee at 90, 100 degrees, 2 weeks, that's right where you need to be. 60, 70 degrees, this is a problem. And then I would have this discussion with them. Now I see the patients back in a month because I'm using that Praneo Dermabond closure, so there's no need for them to come back at 2 weeks. So occasionally I'll catch somebody at 4 weeks now that is stiff, but Also, you have to have a good sort of rapport with your local hospital physical therapists, and if they're the outpatient physical therapists or home health physical therapists, because these are the people that are seeing the patients on a regular basis. And if they capture a patient that is moving slowly, I prefer that they alert me so I can capture this person early and have a big discussion with them about, what's going on and reiterate the importance of early range of motion. We're also using an app-based therapy program. So for some patients, that's all they have. And, it's a matter of having patients taking a picture or having their, family member take a picture from the side so you can see. I truly believe that in the future, we may have a lot more options as far as Bluetooth-enabled braces where you could not only have a patient wear this to document how many revolutions per day they're getting and what range of motion, but also setting up this alert system that, if patients don't hit certain marks by certain days, alert comes through to you or your office that, hey, here's this red flag because this patient is not hitting the parameters that you're looking for. So it's really important to kind of check and see, where patients are. So let's say now the therapists have called me or the patient's in my office and the complaint is stiffness. Now, the important thing is understanding, are they actually stiff or is it a subjective sense of stiffness? These are the people, pre-op, they measure 110, and now someone has 120, but their big complaint is, but my knee is stiff. So this is a person that has 10 degrees more range of motion than what they had preoperatively. I'm not concerned about this person getting stiff. This is a perceived sense of stiffness because the knee's inflamed or because they do have some scar tissue or the knee's swollen or the tissue's tight. And usually over time, that postoperative inflammation, swelling, sense of stiffness does resolve. What I'm more concerned about is the person that truly has measured stiffness. And depending on what article you read, you're talking about a final amount of flexion or a flexion contracture of greater than, or an arc of range of motion less than. So all of those articles have discussed different definitions for what they term, quote, stiff total knees. But you're really looking for people that haven't hit the mark. So early on, I'm not concerned with someone at a month that has, 3-5 degree flexion contracture. I'm even less concerned if it looks like they have a flexion contracture and passively they have full extension. The extensor lag early is normal, again, due to weakness. But I'm definitely concerned with the flexion contracture of 10-12 degrees because that's going to be really hard to get back. And I'm really concerned with flexion of less than 90 degrees because, again, that's going to be really hard to make up at a month. So I set the parameters with my patients ahead of time as you leave the hospital at 90, at 2 weeks you have 100, at 4 weeks it's 110, at 6 weeks it's 120. And they know that any time that they don't meet those goals, they're behind the eight ball. So we're checking this range of motion. So if I catch someone that's stiff, I don't, pull the trigger right away and go, oh, we're going to set you up for a manipulation. I have this sit-down discussion, and this can be a long visit because you're usually dealing with pain or anxiety or swelling, and you have to treat all of these things. The fear of physical therapy, the fear of bending their knee, the pain issues, what they're taking, what they're not taking, what the side effects are. The things that you can control, become swelling. So compressive wraps, TED hose, knee sleeves, ACE wraps, swelling control, icing, inflammation, control, elevation, making sure that they're in a good regimen of non-narcotic pain medication. And then the other important thing is regular physical therapy throughout the day. I really try to explain to the patient that feels they're being diligent because they're doing a half hour of exercises twice a day, but for the other 6-8 hours, they're sitting on the sofa or the recliner, which is even worse. The recliner sitting with the knee bent because it's the most comfortable is the worst thing for someone that has a stiff knee. So I'm trying to make these patients every hour on the hour get up, get moving. And what they start to realize is more frequent range of motion leads to less pain and also improves range of motion, and they do get less stiff. So we go through this battle of what are they doing exactly? How often are they doing it? How much effort are they putting into it? And then for me, these are the exercises that I've talked about before. My two simple exercises, the one for extension and the one for flexion, I review with the patient. So if it's an extension issue, I have these patients do that extension exercise every hour while they're awake. and they'll do that for 2, 3, 4 weeks. Or if it's the flexion issue, every hour while you're awake, they're doing this exercise in addition to their other therapy modality. So, again, for brief review, my extension exercise is sitting in a chair, foot up on another chair, stool, or ottoman. Actually great if it's on a hard surface with wheels because it'll push away. And then firing the quad first because that relaxes the hamstrings to try to straighten the knee. And then with the hands, adding 2 pounds of pressure to push the knee straight. This not only works on stretching out the capsule, stretching out the hamstrings, getting the leg straight, and they'll hold that position for 10 seconds, relax, repeat 6 times. So it's a 1-minute exercise. And then they'll do that every hour while they're awake, in addition to their other physical therapy exercises. And if it's someone that's having issues only with extension, I tell them, listen, 50% flexion, 50% extension, you're doing great with the flexion. Let's put 75, 80% of your time and effort into extension exercises and not as much time on flexion. People have a tendency to want to do what's easy. The flip side is if someone's stiff with flexion and they're doing good with extension, I work on the exercise for flexion. So that's sitting in a chair, sliding the heel back an inch, locking it in place, slide the butt forward an inch, hold it for 10 seconds, don't move the foot, slide your butt back again, slide your heel back again, hold that, and then slide your butt forward, hold that for 10 seconds, sit back, relax, slide your heel back again, slide your butt forward again, hold that. And again, you're going to repeat that 6 times. So it's a 1-minute exercise, and that helps stretch things out. I'll tell the patients it's like being outside in Wisconsin in February and trying to pull taffy. You can't do it because the taffy's cold and hard and brittle. So you got to warm it up. So these little exercises every hour keep the knee loose. So now when you sit down to do your physical therapy, the knee is already a little bit looser than it would have been if it had been sitting for 3, 4, 5 hours. So they're going to gain a little bit more with therapy. Now, other tricks, once the wound's healed and the swelling and the warmth aren't so much of an issue, the other trick that I have with patients later on is they can use a heating pad, or if they have access to a hot tub, getting in the water, using a heating pad to warm the knee up, it makes it a little looser, and then they can gain more flexion. So it'll be heating pad, exercises, followed by ice. And then, the other thing is the bike, which I'm a huge believer in. I like if people have a recumbent or sit on bike at home because they can get on the bike and pedal for 2 or 3 minutes, warms the knee up, drop the seat down a click or closer to the pedals a click, pedal for 30 to 60 seconds, drop the seat another click, pedal. And then they get to a point where you can't complete a revolution because they don't have as much flexion. It's just back and forth. But this way, the patients know if I started at, hole number 17 and now I can get to hole number 12, I've made those gains. And these are things that the patients can do at home. And I discuss in the office all of this stuff, and I will sit down and I will do these exercises, and you can see the patients that cry and they're hurting. And I really just walk them through it and hold their hand and explain how important it is, because if they don't get the flexion, I explain that the stiffness that they have and the pain that they have is going to be with them the rest of their life. So this is that time to put the effort in. And I don't tell them, you should have done it more in the past 2 or 3 weeks and it wouldn't be like this. You don't want to put that out there. You can know that in the back of your mind, but that doesn't help the situation. So you let the patients know that you're here with them. This is what you're dealing with, and this is what you're going to do to help them get better. You can make sure that the physical therapist is seeing them on a regular basis and making sure that they have a goal, and you measure them. And then I have them come back in 10 to 14 days. And I explain to them, depending on how stiff they are, I'm going to watch them every 2 weeks. If we're getting closer to that 10, 12-week mark, I might say, listen, I'm going to see you back in 2 weeks. And if you're not 10 degrees more or 15 degrees more, I'm going to recommend a manipulation. Or I'll even put someone on the books. Hey, I'm going to put you on the books in 3 weeks. I want to see you back in 2 weeks. And if you haven't gained this much range of motion, then we're going to talk about a manipulation. But if you see somebody come back in 2 weeks and they're making gains, just wait. Somebody that's improving has the potential to improve on their own. And we're talking about going from, 80 to 90 to 100. If you got someone that's at 50 and now they're at 60, those gains are not significant. And that's someone that I would say, listen, we probably need to manipulate you, and we need to get you into the operating room to help jumpstart this. Hopefully you do not need to, but it is something to consider. So with my manipulations, I've done arthroscopic along with manipulation. I personally haven't found it's been significantly helpful. So I used to do it. I don't do it as much anymore. But what I found is very interesting with manipulations is there's two kinds of manipulation. So this is a person that, you've controlled the pain, you've controlled the swelling, you've worked with them, you've worked with their physical therapist, and, you're getting 6-8 weeks and you're getting nowhere. And they're really, really stiff. So what's interesting is you put these people to sleep. And, I measure and I photograph and I document. And you're looking at, is it flexion, is it extension, is it both? Do they have good patellar mobility? But what's interesting is you put some people to sleep, and you pick them up and you don't have to push that hard. You just kind of pick them up and they actually bend more asleep than they did in the office, which, is probably related to pain. There was some pain phenomenon. And you push a little bit, and you get pop, pop, and the whole thing goes, like heel to the butt, 140 degrees. Those are people either, in my opinion, that had very, very low pain threshold or something inside was tethered. And I don't really see this anymore. Luckily, my manipulation rate is extremely low. But what I noticed was, those are the patients, especially when I was doing arthroscopic, releases first, was these were these tethered bands. And that's the whole reason that I do that release at the end of every procedure, that I think if they had one or two of these bands and you bend them, it pops the band, and now they have full range of motion. Those patients do great. The other type of patient, though, is the patient that is almost a true arthrofibrotic. I mean, this is the person that, put them to sleep and you're putting all your weight into it and you're pulling, and it's every pop, pop, pop that you hear, you gain 2 degrees or 5 degrees. This is some type of fibrotic biological phenomenon that occurred inside the joint. And these are the patients, unfortunately, that are probably not going to do well no matter what you do. You're going to gain, this is the one typically, you gain 30 degrees, they keep 15 if you're lucky. And that's what I explain to patients. Whatever I gain, you probably will keep half. And, I set these patients up early in the morning and have physical therapy that day. I tell them, hey, listen, you're going right from the hospital, right to physical therapy. And these are the people that need aggressive outpatient physical therapists. Some patients, they do fine on their own. Home therapy program, exercises, app, you tell them what to do, they do great. But the person that's getting stiff needs an outpatient physical therapist and an aggressive one. And if you know people in town, you're going to find there's some therapists that are not super pushy. They're going to massage and manipulate, and they're always afraid to hurt people. But you're going to get the other therapist that understands that you got to hurt some people to make them get better. And this is the patient that needs that kind of therapist, someone that is going to feel bad for the patient, but even though they're hurting and upset and maybe crying, that they're going to keep pushing them to get the range of motion in that early postoperative period. So I hope this kind of gives you sort of an overview. Again, the importance of preoperative education so patients understand that this is going to be hard and this is what they need to do. 2 is the intraoperative sort of tips and pearls of obviously balance the knee well and restore the joint line, bovie around the femoral component superiorly, and the postoperative photograph I find is very valuable. But then 3, having a way of catching patients early and not jumping to the manipulation, but bringing them in, teaching them, reteaching them, coaching them, holding their hand, walking them through this process, and then seeing them back in 2 weeks or every 2 weeks if you need to make sure that they're progressing in the hopes that you prevent the need for a manipulation. And then if you need the manipulation, make sure that you set up aggressive physical therapy that will begin the day of the manipulation. So that's kind of my 2 cents on stiff total knees that you'll see early after surgery. Thanks for listening. If you think this is enjoyable and you have other residents, colleagues, friends that you think would benefit from this information, please share the podcast information with them. You've been listening to the Total Knee Tips and Pearls podcast. Until next time, I'm Adam Rosen. You've been listening to the Total Knee Tips and Pearls podcast. Make sure that you're subscribed so you'll be notified of future episodes. And please take the time to leave a review. It helps other people like you find the show. Until next time, stay safe.